Need to get back. So my name is Angie Kramer. I'm one of the physical therapists down in the rehab department. Back in September, I went to a seminar. A couple of different companies are doing dry needling certification, and so I went to one. They're based out of Bethesda, Maryland, but I was fortunate enough to find the Wisconsin Physical Therapy Association was sponsoring a class in Eau Claire, so that was awesome. I got to go to Eau Claire rather than Maryland for this course. So we'll get right into it. What is dry needling? Basically, dry needling is exactly what it sounds like. You take a real thin needle. They're varying lengths. I brought a couple in to show. They're extremely thin. And the length is going to depend on what area you're doing. If it's a big muscle, if it's a thick muscle, if it's a really small muscle. I should have brought, the longest ones that I use are like 75 millimeters, and those are typically for like going all the way in through the glute or something like that. So you use that thin needle, like I said, varying sizes that are directed into trigger points or knots into the muscles. It's specifically performed into the muscle tissue. And it's very specific. So it's not just that your hamstring's affected, okay, we'll just randomly stick needles in your hamstring. You're using your palpation skills, finding those trigger points or knots, and directing the needle right to those locations in hopes of getting the desired twitch response, which is very, patients know if you got it because they feel it. So what are the needles like? I kind of jumped ahead and talked about that. This one is a 60 millimeter, and it depends, like I said, based on the depth and the size of the muscle. All of the needles have kind of the standard, I'll show you this. They all have a standard width, I guess, if you were a circumference, real small, but the length is what varies. Okay, so is it the same thing as acupuncture? That's probably the number one question that I get. It is not. So acupuncture, I don't know a lot about acupuncture. I think from what I do know about it, it sounds like it's a very effective treatment. But acupuncture is based on traditional Chinese medicine, and it focuses on treating meridian points. We do not claim to do any of that. That does not fall within our scope of practice. I cannot use acupuncture in documentation or anything like that, or talk to patients about, mobilizing meridian points or energy flows. And I think the other big difference, acupuncture, a lot of times they'll use a lot of needles. They might not treat directly the area of the pain. Like your hand represents different parts of your body. They might stick multiple needles in and you might sit with them in. When we're doing trigger point dry needling, it's applied directly to the muscle that's causing the pain. It might not be the location of pain, but it's a specific muscle, and you're going into the muscle. Acupuncture is typically more superficial, just into that skin and fat layer. So what even is a trigger point? We all know, like, oh, I've got this knot, those hard spots in the muscle. Some of them are really easy to find, and then other ones are definitely a little more evasive. But they're a very specific, palpable knot in that muscle tissue. They develop for different reasons. Overuse, injury, muscle strain, poor posture, things like that. It's always associated, so this is kind of a big deal. You have that knot that you can feel, but that knot is always associated with a taut band, like a tightness that runs from the start to the end of that muscle. And that's really what affects your muscle. When you have that tight band running through there, typically when we activate a muscle, all of the muscle fibers in that muscle activate in a coordinated, smooth contraction. And that's where we gain our strength and our function, our coordinated movement. When we have those knots in the muscles, a couple of things happen. We get that taut band, which affects your body's ability to to produce a coordinated contraction of that muscle for contraction. But other things happen when there's that trigger point 2, we have less blood flow to the area, the pH in that area goes down, chemicals are released, so then you start to get kind of like localized pain and, just localized changes to that muscle that's affected. So a big thing that I kind of mentioned before is sometimes the muscle involved hurts where the muscle is. Sometimes your pain might not be at that site of the muscle. So muscle, this is kind of a newer thing or a newer concept that muscles can refer pain. We all think of, oh, I've got pain down my leg, it must be coming from my back. That's a nerve compression, nerves refer pain. Muscles can also refer pain. And there's been extensive work on this since the 30s, really 1930s, that a specific doctor started kind of mapping referral patterns for different muscles. And it's very systematic. The upper trap, and I think I have that on here. Well, I'll get to that in a second. So the upper trap has different trigger points that develop within it, and those different trigger points have different referral patterns. So one closer right up here is going to refer pain kind of in a C shape up the back of your neck, kind of to right behind the eye. And one that I've been seeing people with plantar fasciitis. So that's been interesting. We've had in therapy, people with plantar fasciitis pain. You treat, we kind of do the same things. We'll ultrasound it, we'll manage the symptoms, we'll tell people, supportive footwear, cushion, we'll do ultrasound, we'll do ionto, we'll do deep tissue, we'll stretch. Some people respond beautifully, and then some people don't. And that's really frustrating for us as therapists. We're like, why did this person get better and this person not, And, is the patient not listening to what I say? Is it, that type of thing. But your gastroc, your calf muscle, specifically a trigger point kind of on the inside upper part of that, can refer pain directly down to the arch of the foot. So it can mimic plantar fasciitis. So if the patient's referred for plantar fasciitis pain, and really the source is the muscle, we can treat the plantar fascia all day long, and we may not get a positive response. So it's been a nice addition to what I can offer patients if they're not responding to more traditional therapy. Real quick note on muscle pain is often very vague. People kind of come in and they say, I don't know when it started. I think it started around the summer, and it kind of hurts here. Well, it kind of hurts all over. It's just very difficult. And so right off the bat, even in our eval, we're kind of struggling a little bit more because the complaints are so vague. But I think that's just a take home. It's often not like, yeah, it hurts right here, So kind of just how does this all play out in the clinic? So someone comes in with complaints of headache, or they're having, complaints of headaches. You go to their doctor, it's finally annoying enough, they're like, I gotta get this looked at. They go to the doctor. The doctor might diagnose them with tension headaches or just headaches and send you to therapy for evaluation. So we do our eval and, determine that it does seem like a muscular source. Or, there's all sorts of other things to be ruled out as well. Cervical disc injury, facet lesion, just postural dysfunction. But if on the eval, in this particular situation, the patient says, it starts right behind my eye, just right behind my eye, then it seems to kind of do this, or I get jaw pain with it too. That's when, we kind of say, oh, well, that upper trap trigger point right there really has a hot spot kind of behind the eye, in the jaw, kind of up the back of the neck. So, that's kind of how we would say, maybe we should investigate that a little more. So the goal of dry needling is to get that needle right into that very specific trigger point and get that twitch response and relax that taut band that's running through the muscle to restore normal muscle function. Often, this is kind of interesting, and probably all the PTs in here, which thank you very much for coming to support me. They all know this already, but they're just so sweet. You know, we have that person with the weak hip and we strengthen them all day long for 10 visits and they aren't any better, and you're just like, what's going on? Why are they not getting stronger? A lot of times they just have the underlying muscle dysfunction, and that muscle cannot, you know, get that smooth coordinated contraction, so it doesn't matter how much you strengthen. We need to treat that muscle first. And often you will just spontaneously regain some strength by resolving that trigger point. So, does it hurt? This is what everybody wants to know. No, not really. Okay, maybe just a little. It's different for everybody. I definitely, what people tell me the most is me squeezing that muscle, trying to find those trigger points. They're like, just needle me already. That's killing me. The needle doesn't bother, you know, once I kind of do that to them, they're like, yeah, needle me, whatever. It must not hurt too bad. I mean, so to get certified in this anyways, all the muscles that I do, I had to have done on myself. So I'm very aware of what it feels like. I don't love it, but you know, I also wasn't in a lot of pain. I didn't have an injury that I was wanting treated. So a lot of conversations about that with patients, and they're like, if it's going to get me better, I'm sick of this pain, I'm more than happy to do this, it's not that bad. The other interesting thing is, I'll feel like they're better, and I'm like, okay, they still want to come. Like, they're like, nope, I think I need another session, or, and I'll be like, really, it seems fine, and they're like, no, I think just one more, okay. Or, you know, I'm needling them, and they're like, what about this? Like, do you want to check this? Do you want to needle that? And I'm just like, geez, it must not be that bad. So, I really don't think it's terribly uncomfortable. Will I get better right away? Depends on if it's truly the source of the pain. You know, sometimes I'm finding a trigger point, and yes, it seems like that's causing a problem. You know, maybe it is a trigger point, but it's latent, it's not really active. That wasn't the actual source of the problem. It might be causing some of the problem. Usually people, I feel like they're able to say right away, or in that treatment session, or when I get them up off the table, they're like, oh yeah, like that, I feel sore. You know, I feel sore because you were sticking needles in there, but it feels way more loose, or, you know, I feel like I can take more weight on my leg. Or, you know, if it wasn't that helpful, they're like, we'll have to see what it feels like tomorrow. It feels about the same, you know. So I do always tell them, you know, post-needling soreness, 12, 24, even up to 48 hours. But that's managed by stretching, which I always teach them, and then heat as well. Did you guys want to see a video of it? I didn't.
Sure.
So, hopefully.
Did it hurt you, Patty, when she did it to you?
Yeah.
It was more, I don't want to say, it wasn't pain, but it shocked me. That, I don't even want to say shocking, but
And it can reproduce. If you hit the right spot, it can reproduce your referred pain. So it doesn't always reproduce referred pain, but that's the desired. So sometimes I'll be needling people and they'll be like, oh, I'm getting a headache, or, you know, and I'm like, is that the headache you usually get? Yeah, good. That's a really good sign. And that only lasts, you know, not terribly long, a few minutes maybe when you're done needling. That typically resolves pretty quickly. I don't know, it doesn't look like that's going to come up.
I can share my experience.
Oh, okay.
I've had Angie do trigger the therapy on me, and the only time it hurts is when she does hit the trigger point and it refers the exact pain that was happening prior.
It's like a thorough palpation is required. Due to anatomical variations in and around the popliteal fossa, this is especially important when dealing in the younger portions of the gastric venous. The true effects of the proximal medial head lay between the tibial line and popliteal vessels and the tendons of the medial hamstring, which should be medial in an anterior and medial direction. Conversely, the lateral trigger points lay between the tibial nail and the perineum that runs close to the biceps femoris tendon. This should be medial in an anterior and slightly lateral direction.
Showing the different, so for different locations in the muscle, to avoid arteries, veins, nerves, you have to know which direction to be needling in.
trigger points and talk bands, the needle can then get inserted in a posterior anterior direction. When needling a humerus is
Just tap it in.
the needle should land.
When you tap it in, it really just goes into that skin layer. Usually you don't even feel that, and then you would penetrate into that muscle layer. And then you usually kind of up and down to try to get that trigger point. And
That's the piece of.
yeah. You know, that doesn't hurt. You don't really feel any of it until you hit a trigger point. And then you get kind of like almost like a sudden muscle contraction, or like, you know, when you get Charlie horse. I feel like it's real brief that. So questions at all?
So how many times might you have to get that done? Like
That's a
usually more
good
than
question.
once or twice? Or?
Yeah. Well, I apparently am very impatient and I clicked on it multiple times. It really depends. I would say I've had people respond really quickly with just 2-3 treatments. And man, I had one girl with plantar fasciitis that had failed her initial course of therapy, had 2 injections, referred back to therapy, kind of just like, I don't know what else to do with you. She'd been in a boot. She 8 out of 10 pain. Like she was limping and, you know, miserable. And after her first dry needling treatment, she came in kind of, I wasn't sure if I needed to come back. Like, I'm good. It's like a 2. And so that was awesome.
And you may never need it again.
Right.
It just depends.
Yes, it really does. Yep. And so we did do a couple of follow-up sessions, which were probably good because she did have tons more twitches and responses and stuff. But, you know, from the first treatment, I think we saw her maybe 4 times. She never went back up beyond that 2, which surprised me.
So
I was
where
like,
did
wow.
you do the dry needling for that?
So I did it up in the calf there, but also just kind of thoroughness, like she had some spots in her soleus also, which that typically refers more like to the heel and like Achilles tendonitis. So she wasn't having pain there, but there was some muscle dysfunction, there was some trigger point formation, so I did just treat those as well, just trying to be more comprehensive if that was contributing to the problem. So
How about insurance? Do you cover it?
we're really kind of getting into that. So Medicare does not cover it, so that's a real big limitation. We're trying to work on, actually I need to talk to Nicole, we're getting the ball rolling on, can we do a private pay? You know, so if someone with Medicare, we might be seeing them for therapy, but they also want to add, you know, we say dry
Sure.
needling would be appropriate, it's not covered, would you want a private pay for it? So our hospital insurance pays for it.
So it's what it is.
Yeah. No,
Probably goes towards like therapy visits?
Yes,
Or towards that?
absolutely. Yep.
Okay.
yeah, it would be under a therapy visit. So you might not just have dry needling that session, you might have manual therapy, Therax, things like that too. But it would count, we have 50 visits a year, I'm pretty sure, in our Cisco. So, yeah. that would cover it.
Okay, great. Well, thank you.
Well, thank you for coming. Like I said, I'm very
This was great
impressed
to know.
that
Yeah, might be